So I wanted to welcome everybody tonight to our Florida Foot and Ankle Fellowship Society webinar series, the Roundtable of Excellence. And tonight we have a really good program for you. We're going to be touching on total ankle arthroplasty and its current status, and hearing from several different panel members with Dr. Warren. And basically, we've gone over mission, but basically our goal as a society is to elevate the profession through fellowship training and plant the seeds for tomorrow's thought leaders and educators. These are the participating programs. So we not only have fellowships in the state of Florida, but we also have a few fellowships from around the country that are going to be participating in the series. We've had a really excellent series so far, and I think that this whole webinar series will continue to grow. And we've been very thankful for the programs that have participated already, and we're looking forward to tonight's lecture from Dr. Warren's program. Or Dr. Windram's program, sorry. The Roundtable of Excellence, our goals are education, exposure, promotion, and basically sponsorship, which is giving back to the fellowships. And it's a year-long series. It's every Thursday night, although there's a possibility we might be moving this to Tuesdays. It just seems like Thursday is pretty conflicted for a lot of us. So just kind of watch the Florida Podiatric Fellowship Society webpage, Florida Foot and Ankle Fellowship Society webpage on the FPMA website, and that will give you updated calendars. Our next lecture is going to be Peaceful Transfer of Power, the Art and Science of Tendon Transfers, and that's going to be by Dr. Cottom, the Florida Orthopedic Florida Orthopedic Foot and Ankle Fellowship Program. And without further ado, actually, I lost my screen here. Give me 1 second. Can you guys still see my screen?
We see a Zoom.
Okay. Yes, I see his screen.
Are we still back on the Roundtable of Excellence?
No, that's gone.
Okay, sorry, I don't know what happened there. Give me 1 second. I don't know what knocked me out of that. Give me 1 second. Karen, can you talk for a second?
I'd be happy to. I can tap dance, I can juggle.
Yeah, somehow I got knocked out of my web meeting. So anyhow, basically I was going to introduce Dr. Warren Windram. He's going to be starting tonight's topic on the total ankle arthroplasty and the current status. And we did want to give special mention to our sponsors. Our sponsors so far have been excellent, have really brought this series forward and brought the whole Foot and Ankle Fellowship Society and have made it possible. And that's Stryker, we have Organogenesis, we have MedArtis, we have OMI, and we have Paragon 28 and TriMed. So we're very grateful to the sponsors thus far. And without further ado, I will go ahead and hand it over to Dr. Windram. And Warren, I think you are on mute.
Unmute yours.
Yeah.
Yeah. Could you hear me?
Yes, we can hear you.
Yeah.
Going on auto.
Perfect. All right, guys, welcome. Great turnout tonight. Pretty excited about this. We're really excited that the FPMA has decided to, give us the opportunity to develop the foot and ankle fellowship society. It's great exposure for the fellowships. It's a great format to bring some of our experience and cases to the forefront. Great for students. So we're real excited about this, and we hope this, goes on and it gets much more popular. We're getting pretty good feedback from the particularly the students and some colleagues who have signed up for the seminars. So we're pretty excited about it, and we do thank the Florida Podiatric Medical Association for spearheading this, and particularly Karen Lambert for all her hard work to get this thing to fruition. So we're pretty excited about it. So tonight's talk is going to be on current concepts in total ankle replacement. Ask the experts. We're very fortunate to have doctors Mills, Spinner, and Cohen here tonight to give us their vast experience in total ankle replacement. So we're looking forward to their talk when they speak about individual cases. At first, I'd like to take the opportunity to simply go over our fellowship program here at Westside. We're real fortunate that the hospital, Westside Regional Medical Center, has given us full support, along with the residency program through Dr. Spinner, to have this fellowship program here. So we're quite fortunate. We're very happy about that. Most of you guys know me. I've certainly been in practice for several years. Always been involved with teaching residents and fellows over the years. So we're real happy to have this program here at Westside. Just a real quick summary of what we do here in the Reconstructive Foot and Ankle Fellowship at Westside. It's a one-year program. Program highlights are that we're both ACFAS certified as well as CPME accredited. Not easy to do, so we're real fortunate with that. We're proud of those two accreditations. The program is centered around advanced forefoot and rear foot reconstruction. We have a fellow-run clinic in the private sector. We do, which is pretty cool, we do a lot of sports medicine. So our fellow does cover some of the high school varsity football teams locally with the trainers. So we get a lot of experience in regard to sports medicine coverage, which sometimes we don't really see the real active stuff that we see on the field as in practice, and certainly not in the hospital. We do certainly, total joint reconstruction and arthroplasty, ankle arthroscopy, and we do a fair amount of pediatrics in the program. So it's quite rounded, and it really does prepare the fellow when they graduate to really strive in private practice, either a group practice, hospital practice, or orthopedic practice, whatever practice they may go into. So we're pretty well rounded and fortunate. Basically, in terms of everyday activities, the key that we're real proud of here at this fellowship is that, we are part of the HCA Healthcare Graduate Medical Education Network, and that spans throughout the state of Florida. The program is designed to, offer fellows a rewarding educational environment where fellows are provided individualized learning opportunities by faculty and staff who support and sustain one another throughout the quality of care delivery. Our faculty, we'll go over shortly who our faculty is. They are very committed to teaching and education, and they have been for years at this point. It's a well-rounded, like I said, a well-rounded fellowship that will improve and build on the fellows' current skills and add sense of completeness to their total education that will allow them to enter private practice with full confidence in podiatric medicine and surgery. Like I alluded to, we're part of the HCA GME program here at Westside. So there are other residents that we do have here in the hospital, and we're quite fortunate that we have a great facility here in regard to allowing the residents and fellow to have access to private space and computers and all kinds of stuff that we don't have if we didn't have the GME program. So with the HCA healthcare, are the nation's leading provider of quality patient-centered care. And their mission, above all, is basically committed to the care and improvement of human life. So we like the fact that we're part of a bigger picture at this point. So, and it really has helped in regard to our program. And it's great that we also have other residents here. We interact with anesthesia residents, emergency medicine, internal medicine, pathology, podiatry, and general surgery. So it really helps our residents when they do intermingle with other residents. So we're quite fortunate about that. So making the resident program extremely strong, as well as the fellowship. There's some pictures of the Westside GME building. You can see we have state-of-the-art classrooms with individual dictation areas, research areas that are fully exposed to the residents and the fellow, as well as a little quiet space and kitchen area. So they have a really good spot to just get away from everything and do their thing in private dictation rooms. And so we're pretty proud about that. It works pretty well having that available to us. And good news, this week actually went to the grand opening of the newest HCA Florida hospital, University Hospital, which is just a mile or so down the road from Westside. It's our sister hospital. It just opened this week. Went to the grand opening yesterday. An amazing facility, what they have going on there. So our residents will be rotating through that facility as well. And that most likely will happen early next year. And it is affiliated with Nova Southeastern University. It's right next to the university, and certainly a full range of healthcare services are available there within a very active emergency room. So we're real excited about that. That just opened this week. So great exposure, and also really expanding the footprint for HCA and also for our fellowship program. Our supportive faculty here at Westside, you can see Dr. Spinner, Dr. Mills, Dr. Michael Cohen, who runs the VA program down in Miami, Arthur Siegel, who's been in practice for several years, Dr. Chusset and Dr. Emil, who work with Dr. Spinner. They're real great educators and really do a great job with the residents and the fellow. Dr. Ray Kim, along with Dr. Pappas, who works at a Holy Cross with Dr. Mills. Dr. Woods, new addition, he's a foot and ankle orthopod here at Westside, and we work real closely with them, and he's a great guy. Dr. Schottenstein, past fellow, Dr. Danny Bell, and also Dr. Harada. This is our supporting faculty. So we do have a very diverse faculty, but extremely experienced. So these are the current fellow, Dr. Amin, who's here with us tonight. And these are our past fellows. Dr. Epstein's up at an HCA facility in Gainesville with his wife. Dr. Allen is in Miami Lakes here in Dade County. Dr. Amidi is in Seattle, one of the hospitals out in Seattle doing well. And Dr. Schottenstein's in private practice here in South Florida. So we're proud of our past fellows. They're all doing well in the community, and they're good representations of our ability to teach, and we're proud of them. And just to conclude the talk about the actual fellowship program, don't want to put everyone to sleep. Just pretty much we're real proud of our accreditation. So when the students are out there looking for a fellowship, I mean, try to find fellowships that are both accredited with CPME as well as ACFAS. It's pretty stringent in regard to the CPME guidelines. But we're proud to have accreditation by both. And certainly we really push research here at this hospital in this fellowship. We usually have multiple posters and papers to present at ACFAS each year. And this year we will be also presenting and lecturing. Our fellow will be lecturing at the SAMS conference. And that'll be part of the general discussion in lectures. It won't be just like a fellow day. It'll be just also included in the regular schedule, which we're excited about. So the ACFAS National Conference, we do poster presentation and case presentation. So, and also Westside Regional has also a symposium that they conduct annually. All right. The fellowship starts July 1st and ends June 30th, complete 1-year cycle. Excellent. All right, at this point, so that concludes our small little description of our fellowship program here at Westside. We'll pass it over to Dr. Amin. He's going to give us a little overview of the TARs. And then after his presentation, we will then be proceeding to have our experts present cases and tell us what's going on with some of the cool cases they brought tonight. We're pretty excited about that.
All right, guys, thanks for tuning into this webinar. Going to start off kind of with the total ankle replacement overview. And then we'll get into all the main stuff with the case presentations and reviews with some of these docs who've been at it for quite some time. So to kind of start off, talocrural joint. We know that the talocrural joint obviously is the tibia, fibia, dorsal surface of the talus, and you have all the supporting joint capsule and soft tissue structures. What we know about the ankle joint as well, it's a highly constrained articulation. What that means is you have an area with small contact area of contact area surface compared to that of the hip and the knees. So we know there's a lot of peak pressure point in this joint, so it's very important in your body during gait. And the motion throughout gait is multiplanar, and that's also respected in the ankle joint. So why TAR? We have to understand end-stage disease of the ankle joint. So we have primary osteoarthritis and secondary osteoarthritis. And primary osteoarthritis, we know, is very common in the hips, the knees, the hands. But obviously, it's not that same when you look at the ankle joint, the wrist, the shoulders. A lot of that is not primary. And the reason for that is, not necessarily understood completely, but we know that there's, anatomical, biological, biomechanical factors that do contribute to this variability. But what we can respect is we know that total hip and total knee arthroplasty plays a really big part secondary to primary osteoarthritis. But when we look at the ankle joint itself, secondary osteoarthritis in terms of post-traumatic is what really we see and what's really thrown when it comes to replacing that in the ankle. So as discussed, 80% of ankle arthritis develops post-traumatic versus primary. Some studies do show that the mean age of a total hip and a total knee arthroplasty are at the age of 68. But when we look at the patient population for those that have ankle arthritis, they tend to be at the younger end at the age of 55. So this is very important because patients that are younger in this range, you want to give them the longevity of having an implant, something that lasts them longer. So total ankle replacements do provide mobility to the ankle joint, alleviate stress to adjacent joints in the foot. And we can kind of see now that with the new generations, we're quickly overtaking fusion as a primary treatment option. So patient evaluation. When you see a patient in clinic, it's very important to look at weight bearing and not weight bearing aspect of the patient. You want to get that stability, mobility, position of not only the hind foot, but we look at the forefoot and the midfoot. It doesn't end there because as far as conventional radiographs go, we don't really necessarily, just look at our APs, laterals, mortise views, just the ankle or the foot as well, the 3 basic views. You kind of got to understand maybe, Saltzman views, looking at your hind foot deformities, maybe doing like an ortho radiogram. You want something more proximal. You want to take a look at the knees, look at the patient's hips, kind of understanding any supramalleolar or inframalleolar deformities, and understanding if there's any malunions in the bones, because anything that can cause angular deformation. And your best way is obviously respecting and understanding the use of these radiographs. So where does advanced imaging come into play? So we've kind of, with newer technology, we see CT scans and MRIs as modalities that we do utilize, whether it's CT scans for identifying subchondral bone cysts to MRIs, which kind of give us more periarticular soft tissue structures like the deltoids, the lateral collateral ligaments, tendons. All of this shows if there's any, viability in these soft tissue structures that you definitely intraoperatively may use for balancing purposes in the setting of deformity. Real quick, total ankle replacements, we know they've been around for quite some time, and they're becoming more utilized for end-stage ankle arthritis. What we do know is that ankle arthrodesis is well understood, and it's very reproducible. Ankle arthroplasty is getting to that phase. Obviously, with the newer designs, we see improvements from the first generation. That picture in the top left, shows a reverse implant from the hip that was used in total ankle, in the 70s to now. We can kind of respect in the bottom right where you see these more anatomically driven ankle replacements. They're more streamlined for the joint, and with design evolution, you can see they respect ankle anatomy, biomechanics, and the point of these implants is to obviously minimize stress load and maximize stress distribution. So why has total ankle arthroplasty joint replacement survivorship increased? So not only is it because we have better designed implants, but surgeons definitely have a better appreciation of like the male alignment, different planes of deformity. We kind of understand more about, the component alignment and obviously ligament and soft tissue balancing. So why TAR? Obviously, it can help relieve post-traumatic arthritic pain. You can retain movement in patients. You want them, walking and doing their daily activities. Studies also have shown there's lower rates of hospital readministration, decreased, wound infection, reoperation rates, and obviously less stress around the surrounding foot joints. So real quick basics, obviously every system varies, and you got to look at the components of your total ankle system. Tibial fixation will kind of start off as real quick. You have, barrels, stems, pegs, all these different variations from the different generations over time. Tailor fixation has changed as well, and nowadays you kind of see the the chamfered cut versus the flat cuts, and in terms of respect to the talus and how much bone stock you have. We also look at component shape. Constraints big as well, and that kind of falls into play with bearing designs. We know when you see these highly constrained implants for just semi-constrained, we know that fixed and mobile bearings play a big part in that, because obviously if your poly is not as mobile, you're not going to have as much constraint of something that's fixed. You see more bone implant interface. Component fixation, like we said, it can change from cementless to hydroxyapatite coating, and now obviously you have porous implant fixation, porous metal, and obviously the type of poly utilized as well. So I'm not going to beat the general contraindications to anyone's head, but what we can understand is relative contraindications. They say young active patients, previous infection, a lot of ankle instability, severe malalignment, smoking, osteonecrosis. So there's gray areas on what we see as a relative contraindication. Whether there's a diabetic patient, high BMI, obese, is really a lot of controversial literature out there regarding that. But the absolute patient is indicated, and we don't really see a lot in private practice. Probably, the older patient that doesn't have post-traumatic arthritis, the older patient that's not too active, or the patient that has like more than 2/3 range of motion in their ankle joint. It's really hard, or probably almost impossible, to find that perfect patient, put this implant in. And obviously literature still is developing to kind of support when and what is indicated. So during residency and fellowship, this ankle system in specific, the Infinity, is kind of what I've been exposed to, and the docs speaking down the road will kind of give their spiel, because the third generation, second generation implant may have been what they were exposed to before, but we know that the Infinities for the less complex and primary TARs, in bone for something a little bit more severe of a deformity or revision. Then obviously the Envision is another one that's used for complete revisions of total joints. Imaging, we know prophecy as something is correlated with technology with CT scans. It's definitely a game changer in terms of what implants for ankle arthroplasty are going to be utilized, and how this has guided surgeons to kind of utilize it to the best ability for the patient, because you get precise anatomical and mechanical alignment assessment when you get these guides. It gives you a 3D anatomical and deformity visualization. Will definitely speed up, interrupt what you're doing because you have these specific patient cutting guides. It's very accurate. And with this technology, a lot of the foot and ankle surgeons are getting reproducible results. And obviously bone cyst is something you can see. Real quick stat from Stryker now is that over 50,000 total ankle replacements have been done globally. And out of those, over 35,000 have used Prophecy for planning for their joint replacements. And lastly, clinical results. So with these 4th generation implants, long-term studies are yet to be done. It's fairly new. So things that we will see are, example, a 2-year survivorship rate for infinities is about 97.3% in a study with 503 total ankles versus something small as a case series that was done showed 55 infinities at 98.2. So that being said, whether it's a small or big pool, we're kind of seeing the same numbers, and same thing with M-bone, we're pretty much having a high survivorship rate.
Excellent, thank you.
Yep. Yeah, yep. No. Yep. Yeah. Sure.
All right, great. That was excellent. Excellent overview of the TAR. We are fortunate tonight that our first guest speaker, Dr. Robert Mills, he is a good friend of mine. I'm very fortunate to know him. He's a prominent foot and ankle orthopedic surgeon who's been practicing in the South Florida area for several years. He works out of Holy Cross Hospital, board certified American Board of Orthopedic Surgeon. He completed his residency program at Temple University Hospital and a fellowship in foot and ankle surgery at Jefferson University Hospital in Philadelphia. So we're very happy to have Dr. Mills speak tonight to give us some of his experience as well as his dedication to teaching our fellows. We do appreciate it very much. You're up, Robert.
All right, let me just get this. Can you hear me okay?
We can hear you.
Okay. First of all, it's thanks again, Warren, for that introduction. And before I get started, I'd like to say it's a pleasure for me to be part of your program. I think teaching is an important and overlooked part of medicine these days. The hands-on personal interaction with the experienced and the unexperienced, and we can show them the way, not just in the operating room, but often how to think things through. And there's no doubt that the younger residents know the anatomy and procedures, but I think the most important thing is the understanding of indications and patient selection. And it's not so much when everything goes right, it's what to do when things don't go right. And some of those things you only learn through experience. So people like myself, Warren and Steve Spinner, who I know well, there aren't too many things that collectively we haven't seen. So it was an excellent introduction by Dr. Amin. And I'd like to present a case where I would invite your criticisms, your insight, and possible solutions. So how do I get this? Let me go backwards. So this is a lateral radiograph of a gentleman, a 60-year-old gentleman who presented with progressively worsening ankle pain, swelling, aggravated by ambulation and weight bearing. He came from South America. He couldn't give an accurate history, but it looks like he had prior hindfoot fusion, calcaneocuboid telenavicular arthrodesis. At any rate, cleared for surgery, noting the failure of conservative treatment, which included Arizona bracing, injections, physical therapy, icing, unloading, and so forth, and shoe modification. He underwent a total ankle replacement. This is what I did, the lateral projection shortly after surgery. He did very well for the first maybe 6 months or so after surgery. No post-surgical complications, no wound healing issues, and he was doing fairly well. As time went on, he continued to complain of progressively worsening pain, swelling, and limited motion, and subsequent x-rays showed anterior tilting of his tibia, osteolysis on these two views, and a lateral view. And you can see on the lateral projection, it's collapsing. And he's had progressively worsening talar subsidence, progressively worsening anterior angulation, dorsal anterior angulation of the component. And subsequent CAT scan shows extensive osteolysis in the distal tibia, as well as the subtalar component. So the question is, before I ask about solutions, does anyone think with this initial postoperative x-ray that little bit of tilt that I have on a distal tibia, do you think that's the problem? Would the osteolysis occur anyway? You hear about edge loading. Does that contribute to it? What are there any thoughts in terms of a different type of implant positioning that might have contributed to both the subsidence as well as the progressively worsening osteolytic changes in the tibia and talus?
Is that a Salto, Robert?
The scar.
Your volumes of illusion. So if you completely mute yours, you can go.
Placement of the implant looks great. Is that a Salto implant?
Yes.
Okay. Just from my perspective, it looks pretty good. I'd be happy with that.
Okay. And so as time went on, again, you start seeing the osteolytic changes on both views, and a subsequent CAT scan, I have this cavernous osteolytic lesion on the posterior as well as anterior aspect of the distal tibia. And you'll see some cystic changes sitting under the talar component. So my question is, what do I do next? And what are the thoughts in terms of bone grafting, interposition, tibio-talar calcaneal arthrodesis? I have no experience with the Envision. I think that's the name. I'm not familiar with that. Would that be indicated in this situation?
So Robert, this is Adam Perler. One question, did you by chance get like a SPECT CT or white blood cell scan to see if there's any infectious cause? Because this is obviously kind of a balloon osteolysis situation. Right. And you know, whether or not the tibial tray, I mean, obviously the talus is subsiding for sure, but you know, the stability of the implant currently, is it just washing out of the bone? I mean, I think obviously the talus has sunk into or the talar component has sunk into the talus. So I think the very first thing is to rule out infectious cause.
So he had swelling without warmth or discoloration, no fever and chills. He was seen by infectious disease, SED rate, C-reactive proteins, all were within normal limits. And he got a clean bill of health basically from infectious disease. They did not do a SPECT scan on him.
So
Sorry. So how big was this guy, and what was his activity level, Rob?
Pretty big guy, I would say. Actually, he had a gastric bypass after the surgery because of an increase in weight gain. He's probably 260, 270 pounds at this time. He was over 200 pounds when he had his initial surgery. Not very active because in addition to his symptomatic ankle, he complains of back pain, knee pain, hip pain, but this is what's currently giving him the most discomfort.
Yeah. So, as Adam said, that's a fairly, at least on the tibial side, that's a fairly classic balloon cyst.
Right.
Generally due to sharding of the poly and this macrophage infiltration that causes these big blowout cysts that develop.
Right.
Interestingly enough, you don't get a whole lot of subsidence on the tibial component. You get a lot more subsidence on the talar component. So generally, it's a combination of mobility and increased fluid pressure within the compartment that causes that. I usually see that in my heavier patients.
Yeah, he's definitely a heavier patient. You said you said tissue pressure.
Yeah, fluid pressure around the implant, which you have these channels and this exposed bone, and the increased tissue pressure pushes the fluid into these unprotected bony areas, and you get these big blowout cysts. As far as what to do,
you would see that more on the tibial side than the talar side.
The balloon cyst I see more on the tibial side.
Right.
Other type of cysts and subsidence obviously are more common on the talar component.
So
what to do? I'd take out the phone book, find somebody that you don't like, and I send it to them.
Hey Warren, I got a case for you.
Great.
Dr. Mills, Dr.
Yes.
Mills,
Yes.
the folks out in Ortho Carolina, they did a study with the in bone, and what they found was when the implant was combined with a subtalar fusion, that the rates of talar subsidence was much higher. And they felt that part of it was because, the drill or the fusion itself knocked out a big part of the talar blood supply.
Oh, wow. Okay.
So with the triple arthrodesis, many times, you have a partial or sometimes even a global AVN of the talus. And so that's usually the one to go first. Now, when you say the poly, it's the poly that throws off the shards, but what caused the poly to throw off the shards? Many times it's because the implant isn't seated very well. Number two, there was some studies out with folks that had a gastric bypass, and what they found was that the rate of osteoporosis increased because their inability to absorb calcium. So they did some studies distally in the distal joints, and they found that they had also diffuse osteoporosis. And that, leads you to wonder, should we take vitamin D tests and some of the other tests that we do with other folks with osteoporosis before we do these implants to see if they would be in fact secure?
Is this specifically in conjunction with the subtalar fusion?
No. What I'm saying is people with gastric bypasses have a malabsorption syndrome. And many times that causes osteoporosis in the bone. And they found that those patients sometimes had a higher rate of implant loosening because of that. Right. So, you don't know, there are some other institutions right now trying to get a standard for vitamin D, preoperative vitamin D and calcium levels before you implant. So that'd be something to think about in the future. But I'm looking at your pre-ops, and if you look at your pre-op, your lateral view especially, you would think, maybe with the CT, it'd give you a good idea if there's some kind of AVN going on with the talus, or maybe after the joint was implanted that it, threw it over the edge because you knocked off the blood supply. And I think of that all the time because of that study that came out of Duke.
Do you think this is more physiologic or mechanical, the failure?
Well, it's hard to say because you're only showing the lateral view. It'd be great to see the coronal view.
Yeah, I don't have it right.
And so I see the first metatarsal is up a little bit,
The coronal view was pretty unremarkable in terms of alignment or lytic changes.
Right. So the alignment was pretty good on the coronal view. Then could it be that it had to pronate because the first metatarsal looks a little bit elevated on the lateral view?
You would think, do you think that would be causing the lysis?
No, not it. I think if it had to compensate, for a valgus, a forefoot varus, but the heel's trying to get to pronate to get the forefoot down on the ground, it could strain the implant a little bit. I'm just throwing that out there too.
Right.
So I think this is Adam Pro. I do think that the getting the CT scan ahead of time would have been a good idea, because this talus right here looks a little bit sclerotic, and I do think that the point that was just made about the fusions with the subtalar joint, it does somewhat compromise the talus in terms of its blood supply, and so you would think on this sort of ankle. The only problem with STAR, well, I mean, there's a couple problems with STAR, but one of them is that you have to make 5 cuts on the talus, and it's a talar cap. And so there's always questions of whether or not you're going to get necrosis under that cap. The other thing is, because you're taking that tray from the anterior cortex of the tibia and banging it backwards, that allows fluid to get up into the tray if you have a joint that's producing a lot of fluid, and can lead to that balloon osteolysis. And then the final thing is, even though it's a mobile bearing, mobile bearings are good in a sense, because they, the bearing can kind of find its A to P and M to L position. But when you have a fused subtalar joint, and the STAR specifically does not have a saddle shape, it's a flat on flat curvature. If you go to pronate or supinate, and I don't know, was it Dr. Cohen that was just talking? To his point, if you have a varus or valgus foot, that is going to put strain on the metal to bone interface, or you get edge loading of the implant or the poly, and that cracking of the poly can then start to lead to more joint inflammation, more joint fluid, which then can start to wash out underneath the implant. So those are things that you want to consider. And the question is would this same ankle have done better with a newer implant that's maybe a stemmed implant, or a flat cut talus? And I don't know, because I think that the real key was the workup, and trying to understand if there's any cystic formation or sclerotic formation in the area you're planning on putting the implant. I think all of us have been learning that, sometimes the hard way, that it's much better to preoperative image these patients with CT scans to get a better idea. And I think that's one of the doors that PSI has opened, is it's requiring us to do that. So we're seeing some of these things ahead of time.
So in the past, would you have routinely, do you routinely get a CAT scan of your ankles, aside from the fitting of the component, but to assess the physiology of the bone?
I always have, but that's just I got started on STAR, and STAR was notorious for doing things like this. So I was always concerned about cystic formation or sclerotic formation, and you want to have as much information about the ankle before you put hardware in there. So I routinely did, but I know it wasn't really gold standard until more recently. More people are doing that.
A point maybe for the residents is, I've read studies that show with the triple arthrodesis in conjunction with the total ankle replacement, that you only fuse the posterior facet, thereby avoiding the vascular injury to the talus. And this looks like they fused the middle facet, posterior facet, everything. So I'm just going over the idea of compromised blood supply and essentially potentially cystic devascularized talus.
And one other point I wanted to make, and it goes back to the biomechanical. What we know about the ankle joint is that we don't fully understand how it functions. I mean, you have Inman who came up with his theories, and most of our implants are designed based on Inman's axis, but that was done over 60 years ago. And in his study, he pinned a subtalar joint and then took the ankle through motion, which showed an inward cone.
Right.
The star is not designed on Inman's axis. It's basically a front to back straight hinge. So that's one thing that's different. The other thing is Soren Siegler, who is a professor at Drexel. He did a study where he looked at the subtalar joint motion coupled kinetically with the ankle joint. And what they find is that there's a lot more complex mechanics shared between the subtalar joint and the ankle joint. And that could be why we're seeing some of the saddle shaped and some of the shapes that allow more frontal plane rotation have better survivorship. The star does not have any ability to go into frontal plane rotation. And then when you put it on top of a fused subtalar joint, then basically it's just like the pediatric patients that we would have. You know, remember those things where they have a congenital subtalar joint coalition, they develop a ball and socket ankle. The same thing can happen with a fused subtalar joint with a ankle that's not allowing frontal plane motion. So I don't know if that had any mechanical effect on this.
If the problem is in the coronal plane, would you expect to see more coronal deformity on that subsequent AP X-ray as opposed to almost level? I'm looking at the AP X-ray on the bottom left where you see some of the cystic changes. Would you expect to see more coronal plane deformity with the pronation of the foot?
It depends, because the thing is it's also about the breakdown of the poly. So if you're getting pronatory forces or frontal plane forces on the poly and you're edge loading, that can cause the poly to break down into those microparticles. That's the other thing about the star, is that the poly itself is an older material than all the newer devices that we have that are highly cross-linked, and some of the newer ones are even vitamin E impregnated. But these old star polys are notorious for cracking. And so I forgot how long this was in before it started subsiding, but that would be something that would be a concern as well.
It started subsiding before a year. I would say around 8 months or so, we started noticing some degree of subsidence. And the question now is, what do you recommend?
So personally, this is challenging. The CT scan, I would probably do a SPECT CT scan and try to get an idea of whether or not there's an infectious cause.
Right.
Definitely, you're going to need to remove the hardware. You're going to have to deal with the cystic formation. I would probably switch technology if he was committed to staying with a joint replacement, or this might be a good time to go towards total fusion,
Right.
tibio-talocalcaneal fusion.
If he's committed to total ankle replacement revision and the infectious disease workup is negative, how would you approach the distal tibia?
Well, again, you have to understand why it failed. And so checking the vitamin D levels, the vitamin C, see if there's anything going on from an osteolysis viewpoint where the bone can't support a metal tray. As long as that workup is negative, then you can maybe go towards a relatively, more of a stemmed implant. I think that the Envision is probably the best revision for this sort of failure, because you're going to bypass that area of the tibia and you can build a relatively large stem.
Right.
But this is definitely, these are difficult, because if the revision fails, then you're looking at potential amputation as a final solution.
Right.
So these are not easy, and there's probably not any one single answer. The other thing about the talus is that's also where an envisioned tray or plate might help, but you have to really look at the whether or not that can support another bony implant, or sorry, metallic implant. So you might have to go towards a fusion situation, or you would potentially use 3D printing to help create more of a body with dockage down into the calcaneus.
I did a fair number of these implants at the time, and I present this one because this is the one that I've had this type of problems where everything from subsidence to osteolysis to implant malposition. So it was a collection of concerns, so to speak. So I just want to run this by you guys and pick your brains.
Case, excellent. A lot to think about with this case.
Yep.
Okay, excellent. Robert, that's all? You have one case? We're good?
Yes, the other one didn't come out. So
Okay.
this is the one I'm going to leave with.
Perfect. Thank you very much.
Sure.
Thank you, Dr. Mills.
Okay.
All right. Excellent. Our next guest speaker, Dr. Steven Spinner. Happy to have him here. Dr. Spinner completed his residency training at Peninsula Hospital Center in New York, after which he relocated to South Florida to enter private practice. Dr. Spinner currently serves as the program director at the Westside Podiatry Residency Program. He's board certified by the American Board of Foot and Ankle Surgery and is a fellow of the American College of Foot and Ankle Surgeons. Dr. Spinner is also a good friend of mine, and we're very fortunate to have him speak this evening. And he has been an educator in our field for well over 30 years. So we're very fortunate to have him, and hopefully share some good pearls on his cases that he will present tonight.
Thanks, Warren. Give me 1 minute. Let me get this up. Perfect. So this is kind of deja vu for what we had just seen. How do I get back to that first one? Okay. So this is kind of a repeat. This is also a star. It doesn't suffer from as much subsidence on the talar side of the joint as much as the balloon osteolysis that we see associated with that tibial tray. So in one of the meta-analysis that were done, I think it was in 2019 on 2,500 cases, they identified the perfect storm of clinical findings that would lead to this type of cystic change. And what they found was that the implant that was most prone to this type of cystic osteolysis and subsidence were implants that were non-anatomic in design, hydroxyapatite coated, which we'll talk about in a minute, and with a mobile bearing implant design. So I started with Saltos, then graduated to stars, and of course, instinctively, when you look at the star with the mobile bearing, you go, oh, perfect, because now the poly is mobile bearing, it moves around, it's not constrained by either the tray or the talar component, and you go, so this makes perfect sense, because it's not constrained, it's going to be able to absorb three-dimensional stress on it better than a constrained poly. What they found was that this actually was not the case. They found that there was a higher incidence of sharding and edge effect on the mobile bearing poly than on a fixed poly, and that was one of the things that came up time and time again in these studies where they were trying to identify the causes of these balloon-type cysts on the tibia. So when we talk about what causes these things, we talk about, it's either mechanical or biological or a combination of both. And most of the time it's a combination of both. So you have generally some micromotion at the implant bone implant interface, which causes increased fluid pressure, increased fluid production in the joint. And if you stop and think about total knees and total hips, the way those implants are designed, the implant covers most of the cut bony surface. Well, that's not the case with TARs. With TARs, if you look at the tibial component, you'll see that there's still a lot of uncoverage with exposed bones. So we go in and we do, debridements of the gutters. The implant tibial tray doesn't usually cover the entire cut bony surface. The talar neck is usually exposed where we do our exostectomy. So there are a lot of areas where with a constrained area or contained area where you've got increased fluid production because of the inflammatory change that can occur. There's that increased pressure which forces that synovial fluid or the joint fluid into the bone, which gets behind the implant. The balloon cysts that you see on the tibial tray are classic for this debris type of phagocytosis that occurs, where you get this ingress of these macrophages and you get this inflammatory cytokine mediated inflammatory process. So what's interesting about that is that as bad as those cysts look, you usually don't get a whole lot of tibial subsidence until you get more than 1/3 of that area being compromised by the cysts. That's not the case with the talar component. With the talar component, we know that we don't have to see a whole lot of cystic change, and that talar component is much more commonly subsided than the tibial component. So I moved away from mobile bearing. I'm not really sure what my thought process was back when Wright came along. I think they probably had better dinners than the other rep did, so I moved over to Wright. But if you remember when you started doing in bones in particular, you had to hook up this big rig on the leg, and it was very time consuming, and you had to shoot 15 million x-rays to make sure that you got your axis perfectly aligned. When Prophecy came along, it cut at least an hour off of that operating time, and it became a much more fluid operation. I like the idea of getting the CT scans beforehand. I like the idea of having the block where you could fit your cutting mortise or your cutting block onto your artificial or your 3D printed block. And I just found that with the Prophecy Infinity, it just worked more smoothly in my hands. And my long-term follow-up with those, which is probably not that long, it's probably 5-6 years at this point, since I switched to Wright, the results have been uniformly much better. So this is a classic example of a star where I wound up with some talar subsidence, which wasn't as big a concern as the cystic change that was developing in the tibia. So the question was posed, well, what do you do with these things? Well, you can try, if the tibial component is not, doesn't have a lot of motion in it, you can try backfilling that with either bone grafts or artificial osteoblast or whatever you want your flavor of the month is. But typically, whatever started this process is probably still in place. So you have to kind of move away from this implant. Just backfilling that makes give you a couple of years, but it's not going to solve the problem for you. So the way we solved this problem was to revise that with an in-bone for exactly what was talked about before, where you bypass the cyst. And you can see that we backfilled the cyst with bone. Put the stem in. We didn't have to use a very robust stem, and then obviously changed out the talar component as well. We backfilled some of the cysts on the talar component. And the interesting thing about the cystic formation that occurs, so these little tiny cysts that occur, which are almost entirely mechanical, usually are evident within 6 months of the implant procedure. Those big balloon cysts usually don't occur right away. They usually start to develop over a year or two, because that physiologic process which causes those cysts to develop takes a lot longer than the mechanical cysts that develop on the talar side. So we revised this with an in-bone This was a lady, I forget how old she was. She wasn't that old. She didn't have any planar deformity of her foot, so those cases always go much easier. And she, to this day, is doing much better. We got rid of her symptoms and got rid of the fear factor of having that whole thing collapse on us. Questions, insights, concerns, criticisms?
Looks good.
Looks good, Steve.
I would say the nice thing about technology is it's constantly advancing. And the one concern I always have anytime you're doing revision, especially with the in-bone, is the size of that central peg. It's pretty big in the center aspect of the talus. And the nice thing is that they have gone to the Adaptus technology, which now downsizes that stem. I don't know what type of bone you had under there when you pulled off the talar cap, but that'd be the only consideration if you were to do this case today, for example. You know, the ability to do that flat top on the talus, either with the Envision or with the one without that big central stem, might help prevent, you know, future problems with that talus. But those are things that it's exciting to see, because we have newer technology today than we had even 2 or 3 years ago, to help with cases like this.
Yeah, and I have a tendency to use the flat top talus even with primary implants, and I use it because it's easier. I mean, technically, that's really the only reason I'm doing it. But if you think about the mechanics of the chamfered cuts, I often wondered if the chamfered cut top talus is more adaptable to loading than the flat top talus is. I think it's more anatomic. I'm still not going to do it because
Well, and that's a really interesting point, because I think that at first a lot of people were defaulting to flat cut just because it was easier. But when it comes to subsidence, it's an equal subsidence straight down because you're on a flat surface. The problem with chamfer cuts, if you subside on one of those cuts, then the other 2 or 3, depending on, you know, what type of chamfers are there, you start to float, and then you can get fluid under there. So the flat cut, in some ways, and I think that this will play out in the literature in future years, there are some biomechanical advantages to that flat cut, because now you have a flat cut on your tibia that's essentially parallel to the flat cut on the talus, and you're sandwiching the implant between them, and you're not angling anything. And that's the other thing that we're seeing is vertical fixation versus some of the pegs. Now, Wright has both. They have a vertical fixation with the in bone, but then they have the angled pegs, which can invite opportunity for fluid to get underneath that tray if it gets hung up or subsides in one spot versus the other. And that's why we're seeing a lot of vertical fixation in the newer designs.
I think Steve, also with the chamfered cuts, you can't tell if the implant is really sitting on bone all the way around. You know what I mean? You could, you use a cage before you place the implant on top, but you always wonder if there are little pockets of air in between the bone and the implant when you put it in. Well, that's one of the problems I had with it.
Mike, I'm pretty sure that that's probably the case. I'm sure we don't get 100% interface between the implant and the bone all the time. And you can't really identify it when you're taking your x-rays intraoperatively. The other thing is, the OR personnel always ask me if I want a catheter. And then I go, not if I can be out of here within an hour and a half. So anyway, I think I have one more, which is pretty nondescript. So this was an old Weber C. And we know that, just as Tarak had talked about, we know that the incidence of primary osteoarthritis in the ankle is very rare. Some kind of underlying serologic disease like rheumatoid. So most of the probably to a patient, I think most of the implants that I've done were kind of look like this coming in. They were either malreduced ankle fractures or neglected ankle fractures. So, of course, when we got the templates and the CT reports back from Wright on this, they said, "Oh, you need to take out those malleolar screws." And I went, "Well, I'm a little hesitant to do that." One of the early problems that we had when we tried to jimmy out that the talar bone was we used to inadvertently pry it against the medial mal and wound up cracking it, and I hated that sound. So there was a time where we were putting prophylactic screws through, but when I was faced with a case like this, where there are already 2 screws, to take these screws out, you know that you're going to wind up weakening that medial mal. And I'm pretty cautious with not using that as a fulcrum to lever out my tibial bone anymore. But we wound up just, I think, moving this implant over about 2 millimeters to get it out of harm's way, so I didn't have to take those medial mal screws out. And that was the end result. And again, these are Prophecy Infinity implants.
The tibial component looks perfect. Yeah, nice. Really nice.
Yeah, and again, the other guys on the panel and the other people in the audience, we have a tendency, you know, on the early implants I was doing, the major problem or major pain generator that I was getting was gutter pain, like everybody else. So I have a tendency to really get a little aggressive with doing these gutter cuts now that I didn't used to do. But of course, you're exposing bone, and that whole concept of increased fluid pressures, increased fluid production, and cyst formation behind that tibial tray, you're probably just adding into that potentiality.
Dr. Spinner, so are you saying that you no longer do the gutter cuts as aggressively?
No, I still do.
Right.
Oh yeah, because if it takes 2 or 3 years for those cysts to come back or to generate behind that tibial tray, I'll probably be retired by then. So it'll be somebody else's problem. I'll send them to Rob.
All right, excellent. Thank you, Steve.
You know, one other point we talked about, and I'm remembering, we're talking about when you have those big balloon cysts, what do? Well, you can bypass it with your stem. But Schubert had an interesting concept where he was adding rebar and bone cement into those areas to reinforce that tibial tray. I've never done it. I've never used the rebar that he describes, but that might be an alternative if you start to see some of those big cystic changes. And that's all I got.
Excellent.
Steve, did you test the diastasis before you put the implant in there to see
Yeah.
it was unstable?
No, he was pretty scarred down, so he was pretty stable.
Okay.
But we know that probably was one of the inciting factors for why he wound up with the degenerative change that he wound up with.
Steve, this is Adam. What percentage of your cases do you find yourself doing a posterior muscle lengthening with your TARs? And then I guess maybe just give a comment on whether or not it sounded like you were doing prophylactic fixation on your medial mal. Is that standard of care, or do you just kind of judge it on how thick that island is?
No, it's been quite a while since I've done prophylactic screws up into the medial mal. And again, I'm just very cautious when I go and take out that block of tibial bone, not to use that medial mal as a fulcrum when you're starting to wiggle that bone back and forth. But you know, doing posterior muscle releases is interesting because, and this is purely non-scientific thinking, but do I want to increase my dorsiflexion on that implant and load that anterior aspect of my tibial tray by getting more dorsiflexion? Or do I want to keep it constrained a little bit so I don't get that edge effect? And it's a rhetorical question. I don't have an answer to it, but I have a tendency to not be as aggressive with doing posterior releases as I would with other types of surgery like flat foot recons and triples and things like that. Just a thought.
And can you also review your postoperative protocol? How soon are you weight bearing? What's your splint status, cast status?
You know, a lot of it depends on the patient. A lot of it depends on the absolute weight of the patient. You know, it's not necessarily the BMI as much as the absolute weight that comes through and loads that implant. So if I have a good patient and I know that they're going to be fairly cautious, I weight bear some of these patients as early as 3-4 weeks. In a boot, of course, protective, but I partially start weight bearing them at about, and again, on a younger patient who's got a lower absolute weight problem and is not going to be that aggressive, and I trust, Sometimes I'll put them in a boot at 2 weeks and let them start doing some toe touch and some partial weight bearing.
At 2 weeks, did you say, Steve?
Yeah. Don't ever repeat that, especially in court.
All right, excellent. Thank you, Steve. That was great.
You're welcome.
2 good cases. Moving
Does
on.
anyone else let their patients weight bear that early?
I don't.
I don't either.
And neither do I.
I do. I'm kind of in the minority, but I usually start weight bearing after 2 weeks.
Oh, wow.
You guys are a bunch of babies.
Wimps, right? All right. All right, perfect. Our last presenter, Dr. Michael Cohen. We are quite privileged to have him here this evening. Great educator, like the rest of our panel. Extremely dedicated to his patients and his work, and we're quite fortunate to have him share some of his experience today with the TAR program. Dr. Cohen did receive his doctorate in podiatric medicine from the California College of Podiatric Medicine in San Francisco, and then completed his residency training at Jerry Pettis Memorial Hospital in Loma Linda, California. He's board certified, American Board of Foot and Ankle Surgery, and is a fellow of American College of Foot and Ankle Surgeons. Dr. Cohen has been educating residents at the Miami VA for many years. He's the department chair down there, and we welcome him this evening to share some of his pearls with us. Welcome.
Dr. Cohen?
He's not muted.
Great audio.
Yes, he's on. Hey, Dr. Cohen, are you able to share your screen and see if the PowerPoint comes up?
How's that? Can you see it?
We can hear you. We don't see your screen yet.
Okay.
There you go. We can see you.
Okay, I'm just going to start from here, okay?
Perfect.
All right, so this is a case we inherited from another facility. It was actually a patient who presented to the emergency room with this deep wound, and there was a couple of very deep sinus tracts that went straight into the ankle joint. So I called an Uber to see if he would drive him up to Spinner's office, but he refused to go that far from Miami. So we we admitted him because he was septic, and it was a situation where it was very difficult to get his previous records. He was incarcerated for about 4 weeks, and when he came in, there was actual sutures in the area that were never taken out. So we cleaned. Can you hear me? I'm sorry, I hear some background noise there.
Yes.
So okay, so we took him to the OR and we cleaned it up. And as you see here, he's got his implant, which is an infinity implant. So at this point, I'll let everybody join in. What would you do here? How would you handle this? Patient septic, he came into the ER, refuses to go to Dr. Spinner's office. What's your next step? Anybody want to join in?
I would call Dr. Cottam.
I would question operating on a guy who's in jail. Or
How far out is he from surgery?
Well, he's about 5 weeks, Dr. Mills, and he got incarcerated, I would say about 2 or 3 weeks after the surgery was done. The sutures were still there. He wasn't even immobilized.
Well,
So I would say about 4 or 5 weeks.
So we could call this an acute infection. You know, usually we use
Correct.
that 6-week cutoff. And any other? Is he a smoker, diabetic? Any other?
No, he's actually a young guy. He's 38 years old, no comorbidities. He doesn't have diabetes, does not smoke. And gram stain grew, gram positive cocci.
Right.
And we know that what that's going to be, right? So the x-rays, yeah, 38, because he underwent 2 OCD scopes, and they were medial, very deep, and they told him that the only thing they could do after that is an arthrodesis, which he refused. So he asked them for the implant. And by the way, I know that the standard is not to put implants in patients that young, but I have to tell you that that's an issue which could be debated, and we can do that later if you want. But yes, he had an implant put in.
Well, I definitely think that taking the implant out, putting in a spacer in, if he's committed to having an implant again, I think you could probably keep the cuts as is and do about 6 to 8 weeks of IV antibiotics, and then consider reimplanting him as long as everything turns out negative.
Okay, let's say it turns out positive, or you weren't sure.
You mean after you've done all your clean outs and everything?
Yes.
Yeah, so
That's
definitely
delay
not.
technique.
What was that?
Mask delay. Put an implant antibiotic beads, or take out the metal, put an antibiotic beads and space them, and then stage it again.
Okay, so if it's an implant, right? If it's an implant, it's an acute infection, and you had a soft tissue envelope that covered it completely. Then you have a choice to just treat it with antibiotics, remove the spacer, or leave it in.
Right.
If you have a sinus that went deep into the implant, then it's time to consider open debridement and drainage, and either explant it and wait. we talked about a spec CT, and I have to tell you, I've done so many of those, and no one can read them right. And especially right after an implant was put in, the spec CT, you've got either a Serotech or an indium or one of those white blood cell scans that often light up no matter what around the implant because it's a fresh operation. So in my eyes, the best way to rule out an osteomyelitis or a bone infection is to get a bone biopsy. So what we did was explanted it, and we put in some antibiotic beads. And here you could see that we had a chain of beads that were put in there, tobramycin loaded. And I talked to Hodges about this case, and what he told me is that he doesn't use beads. He just used one big block of polymethyl methacrylate, closes it up, and lets the patient walk. And I was uncomfortable with that because if you ever hold polymethyl methacrylate in your hand as it's getting hard, it gets very, very hot. And I don't like implanting it while it's getting hot because of the damage it could do to the bone. So I think the surface area on the bead itself and the fact that it can harden outside or ex vivo before you implant it does a lot more for the environment than if you just put a block implant inside. So anyway, we've got a definition. This is the criteria for periprosthetic infections. This is from the International Consensus Group in 2014. And what they said is if you have one of two major criterias that would include 2 positive periprosthetic cultures with phenotypically identical microorganisms, or the presence of a sinus tract communicating with the joint, or 3 of the 5 minor criteria, that's elevated CRP and ESR, or elevated synovial fluid. Those are if you have a closed envelope. Elevated synovial fluid PMN numbers, and positive histology of periprosthetic tissue, and a single positive culture. Now, when you get multiple positive cultures, it doesn't mean much unless some of the bacteria is repeated, meaning that if you got 3 cultures and 3 of them had enteric bacteria, but every single one of them had a consistent staph, then you know that that's what you're dealing with. So not to belabor the point with imaging, you've got radiographs and CT, and those are only really good in the late stages where you see some lucency around the implant. And the spec CT is also something you can use, probably the best thing out there, but still very nonspecific in my eyes. And the MRI is not very useful here because of the halo it throws. So what's the treatment? Well, with the early infection, we've got antimicrobial therapy, and this is where the ID folks come in to help you. And early infection with symptoms less than 4 weeks would be something that you'd want to treat a little bit more conservatively. No sinus tract, an intact soft tissue envelope, and a susceptible pathogen. Those are things you could probably treat with debridement, a poly exchange, or just antibiotics. So when you get into the deep late infections, then you have to consider deep explantation and debridement, revision arthroplasty, a cement spacer, and then conversion to ankle arthrodesis or BKA if that's in fact possible. So this is what we did after we put the beads in. And if you see over here, you've got a nice open hole, and you've got to figure out a way to close that hole. And our options here include a thicker flap because the split thickness graft is not going to work here. It's much too deep. And we have to figure out how we can close this if in fact the bone shows no osteomyelitis. And in fact, we did grow a couple of cultures histologically with osteo. And one of the things about using a flap here, if you want to go into a revision implant, is that it will increase the blood supply, the microcirculation of the area. And that way the antibiotic MICs would be increased around there. So the STSG is not, it's not an option here, especially because of its depth and the tendons that are visible. So what we have is a local tissue flap. And this is what we in fact did. Free tissue transfers are much harder to do. They're very long procedures that do require a Foley that Dr. Spinner doesn't like. And the tissue flaps are something that not everybody has access to. And being near a university center, I think that's one of the great things that help us out there. So we called the plastic surgeons and they did a CT angio of the lower extremity, and they did this propeller flap. So the propeller flap is based on the posterior tibial artery. And what they did was rotate the flap anteriorly from the medial side of the ankle and closed it down. That gave us a closed environment. And it would probably take maybe 6 to 8 weeks before it really revascularizes and closes well. The thing I didn't like about this choice was the split thickness graft that they placed on the donor site, which would have made it very difficult to dissect off of the bone when you reimplant. So now we have the beads in there. We've got the flap anteriorly, and we can't let this guy decondition for 4 to 6 weeks until the implant could be put in. So here's the beads, and you could see that the previous cuts over there. We put a X-Fix on there and let him walk and start prehabbing actually in our physical therapy floor. So this is a static frame we put on there with the beads inside. And at this point, we thought, what could we do to salvage this? Well, we waited 7-8 weeks, and the ID folks let us go in there after they cut the antibiotic. We ran all the CRP tests and everything else. We found that he would be ready to be reimplanted. And what we decided to do was reimplant using a revision, the Envision talus, because he lost quite a bit of bone as we were trying to shave the bone off the talus to make sure that it was clean and it bled very well. And when we did this, we had to think of the ankle joint line to make sure that it was anatomically in the right place. Now, whenever you're doing a revision, and this is something I always think about, is that you have to be very mindful about the joint line. So if you get it wrong, then what happens is that the talus either rises up, and then you get medial and lateral encroachments between the medial malleolus and the fibula. You got to make sure that you bring it down to where it needs to be. So you have 3 choices: put a bigger tibial component, put a bigger poly, or put a bigger talus in order to get to where you want. And this is something else you need to consider when you want to take down some of that lateral impingement. If you find that it's encroaching too much, think about using a larger poly, and that'll bring the talus down and keep it away from either side of the malleoli. So this is the Envision set that we used, and we used the Infinity tibial component, very much like before, but we recut it because after a while, the bone is not quite the same, especially if they're weight bearing a little bit on it. With the beads inside it, you need a nice flat cut. So we raised it a little bit, and we put a new Infinity tibial component, and we followed that with an Envision. So you could see that area right underneath the Envision talus, which is about like 2 or 3 millimeters higher, like a washer, to raise that joint line a little bit higher. And this is what it looks like post-op. And luckily, the patient did really well. The implant incision was right there anteriorly, and it was kind of difficult peeling this off and making sure that you could get access to the tibia without violating this area, because whenever you stick a split thickness graft on periosteum, it's very sticky, it's not mobile, and it was very important to leave that soft tissue intact. This is him after walking, and you could see a pretty decent dorsiflexion there. The anterior and medial gutters were debrided, and luckily at this point he's not feeling any impingement, and he's doing pretty well. That bulky area in the anterior flap has gone down, and it almost looks normal at this point too. So we got very lucky with that one.
You obviously have higher testosterone levels than I do.
Hey, Doc, can I ask a question, please?
Sure.
Sure. So before you took him back for the revision, which it turned out amazing, by the way, but before you did that, the ID gave you the go-ahead, and did you go back in and re-biopsy the area?
Yes.
Or did you just
Yes.
trust the 6 weeks, and then you re-biopsied him, opened him up, biopsied him, and then closed
Right.
him, and then brought him back again for the total?
Yeah, you know, the standard that we use is wash them out 2 or 3 times before you close it. So at the 3rd biopsy, we waited for a negative histo and a negative culture, but ID still wanted 6 weeks before we went back in there.
Okay. Thank you.
Sure.
Excellent.
Great case. Wow.
Okay, this is a non-union of a pylon. And this is a patient that had a pylon fracture. He fell off of a ladder. He works at a school, and up at one of the northern hospitals, they put him in a monolateral fixator, and they put a couple of medial malar screws and a fibular plate. But he ended up having, you could see on the CT scan here, this non-union. And he didn't want a fusion. I mean, he was absolutely adamant he didn't want a fusion. And we're trying to figure out if we could trust an implant here, and what our options were to try to salvage this in an effort to have him get his dream. So if you see this, it went pretty high up into the tibia. I would say maybe 30%, 25% of the joint surface area was involved here. So we gave him the option to try to clear out all this stuff in here and bone graft it. And this is what it looked in vivo on the operating room table. You could see this huge crevice. And so we thought, okay, we have nothing to lose by trying to graft and see if we could put it together. And if worse comes to worse, we could just fuse it later. So we left we cleared this area up and put a plate and a bunch of screws from end to posterior to see if it would hold, and waited a long time to see if he could heal. And this is the CT scan with it reduced. This is a pre-op right here. And you could see that we got a pretty good fusion in this area over here. So it took multiple CTs to make sure. And we followed that up with an in-bone. So it was a pretty easy thing to do once we got the fusion. But we thought, you know, this is just one of the things you could consider when you have a distal non-union. And fusing, especially if it's more than 25% of the joint line, if you can break down the fusion and fuse it, probably do better. And it avoided the fusion. This is actually a 7-year post-op x-ray of the patient here. So he's doing well so far. And I think that we got lucky with this one too.
Good case.
Looks great.
And this is the last one. We've got a arthrodesis of a ankle, and luckily he still has his fibula intact. he had a pylon fracture and he had a primary arthrodesis at the ankle joint performed at another institution. So he developed arthritis in the subtalar joint, and you could see that the ankle was actually in varus and he was in pain. So the subtalar was fused and a Dwyer osteotomy was performed. It's not really done at the cora. And you could see that the two tracks leading up into the talus is bone paste that we injected after we took the screws out. He later developed TN pain. And there's a lot of studies that show after ankle fusion, you get peritalar arthritis. I think you should take those studies with a grain of salt, because many times these studies didn't really tell you that the arthritis was probably there before the ankle was fused, and or if that arthritis is actually symptomatic. I think Charlie Salzman's article says a lot about the peritalar changes, but it really doesn't break down which of those joints really had arthritic changes prior to the fusion, and it's tough to say. Anyway, there's a feeling that if there's a tritarsal arthritic change and you are thinking about doing a pantalar arthrodesis, you're really converting that foot and ankle into a BK prosthesis. In fact, the oxygen consumption with a TTC arthrodesis is not much different than a BK prosthesis. It's just, it's a leg with skin that can feel. So he developed pain in the TN joint and very symptomatic. And at that point, you think, wow, should I go there and fuse another joint and make this really stiff? And what made this even more difficult was that he was very active and he liked to scuba dive. That the left foot, he wasn't able to really get a fin on. And when he did try to put fins on, he just went around in circles because only one would bend. So we thought, why not, instead of fusing, try something like a conversion to an ankle fusion. So this is just when the prophecy technique came out. In fact, this is the first prophecy technique for an ankle fusion. And so we called the folks over at Wright and we asked them, to see if they can make us a cutting block that could fit around the whole thing. Now, technically, with an arthritic ankle that you're using the prophecy technique for, you're using osteophytes to guide you into where to place your blocks. Obviously, we don't have that here. So we got a block that could fit into the medial malleoli, the anterior tibia, and the neck of the talus. And we had to figure out exactly, again, where the joint line was. So in this case, we did use prophylactic screws before we did our cut. I was worried because Sig Hansen did a lot of these, and he had a study back in 2004. They did like 18 or 20 ankle fusion takedowns, and half of them ended up with a fracture of either the medial or the lateral malleoli. But I thought maybe, the prophecy technique would be much easier, especially because the cuts would be more guided. And thought, well, let's stick the screws into the medial mal prophylactically with a cannulated technique. And that's what we did here. It was actually the lateral mal that I was more afraid of. But if you see the AP views here fluoroscopically, you could really see the outline of the talus, and it was very easy to make out where to place your joint line. And so we did that, the prophecy technique. We stuck the prophylactic screws medially and laterally. And there's the gun sights, and we tailored it to what the Wright medical folks had asked us to do. But if you look right at the fins, if you look straight down at the fins of the cutting guide here, it's right at the level of the ankle joint. And this is where we based you know, pretty much of where our ankle joint line and our implant would go around this area over here. This is a lateral view, and we secured that C bracket with a Steinman pin to hold it in place as we drilled into it. And so that's a lateral and AP view. And again, it was the lateral side, the medial gutters, that had to be taken down considerably in order to get pretty decent motion. So I think I've got a video post-op laterally here, and you could see it's pretty remarkable. And I was planning to do a TAL after the procedure, but when I saw that much motion post-op, there was no reason to do it. And I do have a 8 or 9 year post-op on that patient, and he's still doing well. So far, so good.
Looks awesome.
Well, that's an incredible case.
Wow.
Wow.
All right, excellent. Amazing range of motion there. Amazing. All right, excellent. Well, thank you, Michael. Excellent. That completes our expert panel discussion. We can do a Q&A at this point. Any questions that the audience may have, we can entertain.
So Warren, this is Dr. Propeller. A couple questions that have come in. One person was asking about people's appetite for valgus malalignment simultaneously with with arthritis of the ankle. What's your approach with the valgus malalignment? And are you doing staged, single staged, or kind of double staged procedures for that?
Personally, yes. I do not like seeing the valgus foot and doing it a TAR without staging it. I'm a fan of staging that. Really get a stable heel, get a really good stable strut before doing the TAR. I know some people do, valgus reconstruction procedures at the same time as the TAR, but I don't. But I think, in dealing with the valgus position of the rear foot, that's paramount that gets corrected and stabilized prior to the implant. A varus ankle is very tolerable. We could do 20 degrees of varus. It's a lot more tolerable than any valgus deformity. So I fear valgus deformity, and I really take that seriously, and I try to stage that procedure. I don't know if anyone else on the panel has
Yeah, this is Rob Mills. I posed that question because the thing that scares me isn't so much the varus ankle, where I like to do a deltoid peel, and since doing that, I don't find as much of a need for reconstruction of the lateral ligaments. It's the valgus ankle, and the reason I posed the question is sometimes I think the valgus is more a bony valgus versus a soft tissue valgus. And I was just wondering what the panel's thoughts were. Do they include a Perineus brevis to longus tendon transfer with that, the posterior tibial tendon compromise with the overpull of the Perineus brevis? So does anyone feel there's a need or indication to release the deforming effect of the Perineus brevis tendon and transfer to the Perineus longus and plantar flex that first ray in terms of part of the valgus malalignment?
Yeah, I think if there's an identifiable tendon imbalance, I think that's probably a great way to go. I agree with Warren. The varus ankle doesn't scare me as much as the valgus foot. So when I have valgus deformity, clearly there's a difference if you have a valgus ankle or a valgus rear foot. So a valgus ankle we could usually correct with the implant and some soft tissue balancing. But if you've got a rigid deformity of the foot and you've got a rectus ankle joint or an intact ankle mortise, I'm a fan of going in and fixing the valgus before. I want to get the foot back under the leg before I put the implant in, unless it's just a simple calcaneal slide osteotomy. But if it's any more involved in that, if I've got to do a subtalar fusion, I'm going to do those procedures before I do the implant goes in.
Yeah, my question, I was reading an article, Coatsy, he said 20 degrees, and there's another article said 30 degrees. I was just wondering if there is an angular threshold that you would say, you know, there's not enough rebalancing in the world for me to do this. I'm going to bail and do an arthrodesis.
Yeah, I think 30 degrees is probably way past my threshold.
Yeah. Yeah. Okay.
Okay.
Any other questions?
So there's a couple more questions I have in the chat room. One is rationale behind the flat cut talus, and when do you choose to do an in-bone implant? And I'm guessing that's as opposed to using a infinity tray or lesser invasive tray.
I do the flat top just because it's easier, and there's really no literature out there that shows a difference in the long-term survivability of doing a chamfered cut or a flat top. So again, it's just I just find it flows easier in my hands, and it gets me out of the operating room quicker. And because there's nothing in the literature that would justify one over the other, I'm comfortable doing that. And I've got a bunch of those in, and fortunately, I haven't had much difficulty that I could point to the flat top as the culprit.
Yeah, I would say I do the same thing for the same reasons.
Agree. I do the same.
The next question was, what are your thoughts on using a Salto or Cadence as opposed to Star or Infinity in these case studies?
I've got no experience with the Cadence. The Salto was the first one that I went to. And again, if you're going to ask me why I went from Salto and then started doing, moving up the line, I really can't tell you what my rationale was that many years ago. But again, now with the 3D reconstruction and the cutting blocks that you get, it just again makes the whole process of putting the implant in much quicker and much easier for me.
Dr. Bill Beaton was saying that it's interesting to notice that there appears to be, in these ankle cases, a lot of first metatarsal elevatus. And he was just wondering if there needs to be any consideration for correction of that to maintain the ankle alignment.
I think in the flat foot, a lot of these patients have a flat foot, and clearly you have to do something to balance the foot. Dr. Mills had talked about the Perineus Transfer, which works great if you've got a flexible elevatus or supinatus of the forefoot. If it's not, then you need to start thinking about, when you're doing your rear foot correction, to get the foot out of valgus, to do a cotton procedure or something to bring that first met down, if the brevis longus transfer doesn't do it.
And
Steve, one thing a lot of times when you're looking at the perineals, especially with a varus foot, you don't have much to work with there. And, you'll have the perineal brevis tears, and some of these patients even have calcified perineal tendons. One other thing is we fail to look up, more proximal in the joints. Some of these patients have knee arthritis, and they very often have tibial varum or valgum, and that collapses and causes the distal changes in the joints. So make sure you're looking at the ankle and the hip joints before you're deciding how to fix it. And perhaps you can send them to ortho to get the proximal joints fixed first before you go down.
That's a really good point, Mike, except I'm not allowed to look at the knee. I'm a podiatrist.
Take a look.
Another question was, can you comment on your postoperative dressing protocol and whether or not you favor using incisional vacuums like the Pico drain or wound vac as part of your post-op?
From my experience, I haven't really in the beginning when I first started doing these, the Saltos in particular, I did use a lot of incisional vacs, but I found over time, particularly with really the atraumatic technique for dissection in terms of retraction of the soft tissue envelope, I really have not needed incisional vacs after taking on that technique. I do sometimes use some amniotic products in the closure process. We could debate that either way, but I really do believe an atraumatic technique along with really proper time management in these cases. Try not to get in there for a 4 or 5 hour surgery. I think we really, if we move along with these, with the prophecy system, we can move along. And I really think that decreases our wound complications, really minimizing tourniquet time and really using that atraumatic technique. So to answer your question, I really recently, over the last few years, I haven't really needed incisional vacs, but initially when I first started, I did, and I really haven't had any issues since then.
Yeah, I don't use vacs as well. I agree with Warren, respecting the soft tissue throughout the procedure, careful retraction, use of sutures instead of staples on the skin, and I believe in splinting instead of a cast to reduce pressure on the anterior aspect of the ankle. Those are the basic things.
Agree.
And one more question. A tourniquet or no tourniquet when you guys do your TARs?
Kind of old school. I use my tourniquet, but I drop it at an hour and a half. If I'm not out of there in an hour and a half, I'm dropping it anyway.
I use tourniquet as well.
I'm a fan of a tourniquet.
I don't like that red stuff.
Yeah, it speeds us up a little bit, and I just think it really.
Anybody let their patients bleed during TARs?
I've done it. I've done it a few times, and not because of choice. But, I think there's an advantage to that, actually. You could take care of your bleeders, and you can make sure you have very good hemostasis before you close everything. A lot of times we close a wound and we drop the tourniquet, and that's why we get a lot of swelling post-op. I think it's good sometimes to just drop it before you do your closure.
I will say that in the last 10 years, I don't think I've used a tourniquet on a TAR. And I just really feel like it makes a huge difference in terms of postoperative pain, infection. There's no hematomas. It's really, really amazing. It does take longer, and you definitely have to have an appetite for it. But I think there's a ton of advantages to it. There's not a lot of people nationwide that do it without a tourniquet, though.
Adam, I did both, and I have to agree with you. Ever since you turned me on to that, I've been loving it with the no tourniquet. It adds another 20 minutes to the case, but otherwise it's awesome. So don't be, if you've never done it without a tourniquet, it's not as scary as it might seem.
One thing I was going to add to that is it's definitely part of my multi-module approach in terms of pain control, because what I have found is the majority of my patients are managing their postoperative pain just with Tylenol and Advil, and they're not taking narcotics at all, which is really surprising because it's a pretty invasive procedure. But I really do think a lot of that postoperative pain is due to the dysvascular nature of the tourniquet for an hour and a half, 2 hours, however long it takes us to do the TAR. So I don't really sweat the tourniquet time when I'm not using a tourniquet, and I feel a lot better about it. But it does take some getting used to, for sure.
Excellent, excellent. Alrighty, guys, getting a little late. We could wrap it up. Appreciate everyone's participation, particularly our panel of experts. That was excellent. And we look forward to the next installment of the Florida Fellowship Foot and Ankle Society webinar.